Good evening, everyone. Thank you for your introduction. I am going to present a case of a acute mesenteric ischemia with an open SMA embolectomy. Um, like you guys said, I'm a second year general surgery resident at FIU Baptist Health. So our patient is a 73-year-old female who initially presented to the hospital due to generalized abdominal pain, nausea and vomiting, and diarrhea of 3 days duration. Her only past medical history is AFib, and she was on Xarelto. Her past surgical history was an appendectomy, greater than 20 years prior to presentation. She was a non-smoker. Her only medication was Xarelto, which she stated that she stopped taking 3 days prior to presentation because it upset her stomach. On exam, when she presented to the hospital, she was an AFib with RVR with heart rates between 140 to 150. She had a soft abdomen, mild diffuse tenderness to palpation, and was non-distended. Her labs, her H&H was within normal limits. She had a white count of 20.3. She was slightly hypokalemic, had an AKI. Her creatinine was 1.55. Her anion gap was 24, and she had a lactate of 11. Patient underwent aggressive fluid resuscitation, and that went down to 2.6. Upon presentation, a CT scan was obtained with IV contrast, and I will play it right now. Um, so as you can see, there's a very large clot within the SMA, and the celiac and the IMA are patent. Bilateral iliacs are patent. Um, Unfortunately, this was read as just possible enteritis, and therefore patient was admitted to the um, step down unit in the hospital and was treated with antibiotics for possible enteritis. Patient then continued, she was started on cefepime and flagyl. Patient continued to complain of abdominal pain throughout the day. Um, and then with pain medications, it improved. At approximately 3 p.m., patient began to complain of 10 out of 10 abdominal pain. Repeat labs were obtained. It showed a lactate of 14. A CTA was obtained, and at this point, it was read as acute thrombus of the SMA, as well as bilateral renal, um, uh, bilateral renal infarcts. At this point, general surgery and vascular surgery were consulted, and this was the repeat CT scan. Once again, we can see that there is a large clot within the SMA, and now the bowel is more dilated and starting to have signs of ischemia. At this point, we had a discussion with the patient and the family members that we would like to proceed with emergent intervention. The plan was to go to the IR suite for possible percutaneous thrombectomy of the SMA, and then immediately go to the OR for a diagnostic laparoscopy, and then possible XLAP for bowel resection. Patient was taken to the IR suite without delay. We got right common femoral access. It showed patent, common iliac and external iliac. And then we shot an aortogram that showed the bilateral renal arteries, but we could not see the SMA at all. We then cannulated the celiac artery and showed that it was patent. All three vessels of the celiac artery were patent. And then at this point in time, we were still trying to get access to the SMA. We tried with 014 wires and 035 wires to get access into the SMA. We then measured the distance between the renal artery and the SMA ostium on the CT scan and measured that on the angio and tried to get in, but we were still unable to find the ostium of the SMA. Therefore, we elected to stop the case and then proceed to the OR emergently for an open SMA thrombectomy. And this is a video of us trying to get into the SMA. So patient was taken immediately from IR to the OR. We did a midline laparotomy. As soon as we got into the abdomen, we found a large amount of necrotic bowel and ischemic, but no perforation or gross spillage. So we elected to proceed with a open embolectomy. The transverse colon was reflected cephalad to expose the root of the mesentery. We exposed the SMA, got proximal and distal control. We did a horizontal arteriotomy. We did multiple passes of 3 French Fogarty approximately with a large clot burden removed. We did multiple passes of a 2 French Fogarty distally with clot removed as well. At this point in time, we weren't very happy with our back bleeding, so we flushed with hepsaline and then we gave 4 grams of TPA intraarterially. After that, we had very good back bleeding. The arteriotomy was then closed primarily, and at the completion, we had a strong multiphasic Doppler signal, both proximally and distally. And then we turned our attention to the bowel. There was about 100 centimeters of frankly necrotic small bowel. Sorry, 4 milligrams uh, in the TPA. 100 centimeters of frankly necrotic small bowel was resected. We left the patient in discontinuity, and then we, looked at all 4 quadrants of the abdomen. The colon appeared normal, and then the gallbladder appeared necrotic, and therefore a cholecystectomy was performed. Our thought process was that, she's been showering clots because she's off her Xarelto and is an AFib, and one of the clots also got into the celiac artery and led to gallbladder ischemia. An aphthera was placed and the patient was transferred to the ICU intubated. This was all the clots that we got out that we were able to picture. It was actually a bit more than that. And then pathology showed, superior mesenteric artery clot, and then small intestine with acute hemorrhage and necrosis consistent with ischemia, and then gallbladder also with mucosal necrosis. Patient was transferred to the ICU from the OR. They were on 3 micrograms of Levofed. Throughout the day, patient continued to be hypotensive. Vasopressin was added. They remained on Levofed between 6 and 10 and vasopressin of 0.03 throughout the day. Because of non-clearing lactate, an IJ trialysis line was placed and patient was started on CRRT. So CRT was started around 1400. So as you guys can see, the lactate was going up and then it started going down. And then at 2300, it went up again to 18. Also, patient's liver enzymes were going up, and then she went into liver shock with very high levels of ALT and AST. She had an INR of 16, and at that point we got a TEG, but the TEG showed that she had normal coagulation. So this was mostly her liver shock leading to her derangements in her INR. At 23:21, the next day, patient acutely worsened. The ICU started dobutamine at 2.5. Patient at 23:23 went into PEA arrest. CPR was initiated and they got intermittent ROSCed 3 times. However, at 23:52, family decided to stop CPR and the patient unfortunately passed away. So I wanted to speak quickly about acute mesenteric ischemia. It is, most of the cases, it is embolic from a cardiac source. That's 40 to 50%, thrombotic and 25 to 30%, non-occlusive in patients with hypotension that leads to decreased bowel perfusion in about 20%. And then a rare form of acute mesenteric ischemia is venous thrombosis leading to um, engorgement of the mesenteric vessels, and that decreases the arterial blood flow. The factors that increase mortality are clot burden, delay in diagnosis slash management, and then advanced age of the patient, and then patient with severe abdominal pain out of proportion to exam, as people usually say in all textbooks and everything. With unexplained lactic acidemia, we should always think of acute mesenteric ischemia and try to rule that out. Thank you. Thank you.
Thank you for that presentation. Sorry for the outcome. Obviously, that was a unfortunate but a very instructive case. I think a lot of points in that case that you presented that I'm sure had to do it over. You might think be different. Maybe the system could have recognized that this was an AFib embolus earlier, the patient gets treatment earlier. Um, Take me through the decision making for a patient with elevated lactate and severe abdominal pain and CT evidence of concern for bowel ischemia, of choosing a percutaneous strategy before looking at the bowel. I have to admit, for me, I've never done that for an embolus case, only because if I am going to be looking at the bowel, I want to know how much is viable. Every now and again, I think when you do a laparotomy, you might see that they're frankly unsalvageable. But also, I've found that I think the ability to extirpate the clot is pretty quick when you're doing direct surgery, whereas, like you encountered, it depends. I think the selection of the lesion is important. I mean, the short thrombus maybe, but that was long segment thrombus into tertiary branches of the ileojejunal vessels. And I think that was where he obviously it was going to be technically difficult. It didn't look like you guys employed a steerable sheath or came from the arm, but we could go into all of the technical elements that might increase successive endovascular revascularization of acute mesenteric ischemia, but more the decision point of if you know the patient needs laparotomy, doing an endo strategy and then moving to a separate setting to do that laparotomy instead of just doing it all at once, making sure the patient's viable first and then doing direct revascularization. Any thoughts on that?
The initial thought process was that, the patient had been having symptoms for over 24 hours at this point, was not severely unstable. The CT did not show, imaging findings of, necrosis or pneumatosis in the bowel or anything to show that the bowel is completely non-viable. There have been multiple studies that have shown that, going a percutaneous route first with mechanical thrombectomy, and decreases hospital length of stay, decreases ICU length of stay, decreases operative time, and at the end of the day, similar mortality. So our initial thought process was to try and proceed with a percutaneous thrombectomy and then do a diagnostic laparoscopy. And after the diagnostic laparoscopy, see if there needs to be any bowel to be removed, and then proceed with a laparotomy. But then that would make the laparotomy much shorter and patient off the table as fast as possible. If we had signs in the CT of pneumatosis or something that would show that the bowel is completely non-viable, then we would have obviously proceeded to a XLAP in the beginning and seen if it's if there was enough bowel, obviously, to maintain life. But we felt that the patient was very stable at the time we saw her, so we elected to proceed with the percutaneous route first.
Sure. But
Is
yeah,
a
as you found out in those cases, particularly older women,
Mhm.
they may not have those signs on CT or even clinically, and then you had 100 centimeters of necrotic bowel removed, right? So that's one of the challenges. The lactate's unreliable, the physical exam may be unreliable, the CT can be unreliable because they're very late findings. If you find elevated lactate or if you find pneumatosis, those are late findings, and so
Mhm.
that's always, I think, it's a tough decision. Being aware of the selection bias that exists in the meta-analyses that have been done of endo versus open for acute mesenteric ischemia for thromboembolic lesions. But great discussion. I don't know, Dr. Arnatakis, anybody offer any questions in
Yeah,
the,
so
yeah,
part of one question from Dr. Landon came up about the delay in diagnosis, even before the decision was made to go to the IR suite or cath lab, and then and then piggyback into the OR was there was definitely a delay from a radiographic reading standpoint on that initial CAT scan, where there's clearly no didn't didn't appear at least to be any SMA perfusion. So, do we think that that delay led to worsen the outcome? I think naturally the answer is yes.
Yeah.
Dr. Taubman, also, I suspect this is your case, shared some sort of organizational insight into the decision in doing the cath lab, trying a percutaneous attempt, and then proceeding to the operating room. It sounds like they had a room available and ready to go, and a team available in the cath lab, and that was not the case in the operating room. It had taken them at this hospital a fair bit of time to get the operating room mobilized. And so I think that also seems like that persuaded the decision making to do the approach that was chosen. And she did comment that that hospital does not have sterile sheaths, unfortunately.
Oh, interesting. So yeah, again, always very, very instructive to hear that feedback about that. All these things are relevant to that clinical decision making. I absolutely would concede that, your environment, OR availability, team availability, catheter, wired availability, all of these things, surgical instruments. I certainly practicing between a VA and a university that are across the street. They're like two different countries, so I can certainly appreciate the challenges that came up in that decision making. I don't know if there's anything else, but we might want to move on just because we're already a couple minutes behind schedule if we want to go to the next presentation.